So, Bismillahirrahmanirrahim, in the name of Allah, the most beneficent and the most merciful. We will resume from the place where we left in our last class. But before I proceed, I just want to make one correction. That there was one slide which was written incorrectly, and that was, I mentioned that fat is hypointense, so I just corrected it. And I want to bring it to the notice of all of you, because I mentioned the same, but it was written incorrectly. So some of the participants, being very kind, mentioned it to me, and I just corrected myself, and I want to correct it on this forum as well, because these lectures are being recorded and placed on the website, so nobody should have an incorrect concept. So with this, we will move on to our second part of the same session, which is infratentorial lesions with their differentials. So I will again focus basically on the sequences and how you're going to pick up different things instead of going into differentials and all the details. So when we start with the posterior fossa, as we already started in our previous lecture, that we divide this into masses which are in relation to fourth ventricle in the cerebellar hemispheres, in the brainstem, and in the CP angle. And apart from that, there are other masses which I am going to discuss in the end. So whenever you are looking at a potential brain tumor, you just have to, whenever you analyze this, you just have to see that there are many questions which you need to answer. First of all, you have to look at the age group of the patient, because there are different differentials in the pediatric age group in posterior fossa, and there are different differentials for adults in the with masses in the posterior fossa. So whenever you have masses in pediatric age group, you are going to consider multiple primary neoplastic lesions of the posterior fossa as well as multiple syndromes. But in adults, more than 50% of the masses are, or rather more than 70 to 80% of the masses are metastasis. Then you have to localize that whether the lesion is intraaxial or extraaxial. Which anatomical compartment does it lie, and is it crossing the midline or not? Then after categorizing these two, after going through these two steps, then you come to the MR characteristics, because posterior fossa is best imaged on MRI. On CT, we get a lot of streak artifacts, and we are unable to characterize the location and characteristics of lesions very well. So MR is the investigation of choice in posterior fossa lesions. And after deciding that the patient, looking at the age and parameters of the patient, and then deciding that whether the lesion is intraaxial or extraaxial, then you come to the MR characteristics, that how does it look like on T1, how does it look like on T2, does it have fat, does it have a cystic component, is it showing enhancement with contrast, is it a solitary or a multifocal lesion? Because all these points, when you have a checklist in your mind, then you are able to characterize a lesion in a better way. So always, make a virtual checklist in your mind that how are you going to look at a lesion, how are you going to approach while you're reading an MRI. So after that, I will just reinforce the signs of extraaxial lesion, which have been reinforced in the previous lectures as well. That you have to look at the CSF cleft. For example, on the image which I have shared here from radiology assistant. This is a T2 weighted image. I hope all of you can see my cursor. This is a T2 weighted image. And on a T2 weighted image, you just have to look at the boundary or margins of the lesion. If you can see a CSF cleft along any margin of the lesion, it goes in favor that this is an extraaxial lesion, which is in the extracerebellar CSF space or extracerebral CSF space, depending on the location, supra or infratentorial. And this is pushing from outside and displacing the brain parenchyma, and in between the lesion and the brain parenchyma is a CSF cleft, which is actually the CSF of the extracerebellar CSF spaces. Then you can see that the subarachnoid vessels, they are displaced by the lesions. You can see a lot of subarachnoid vessels which are being displaced by this lesion. Then, especially in cases of supratentorial lesions, you can see the buckling of gray matter, and you can see that the gray matter is displaced by the lesion. If the band of gray matter is seen outside the lesion, that means that it is within the brain parenchyma. But if it is displaced by the lesion, then it shows that it is an extraaxial lesion. Then you have to decide that it is broad-based, it is dural-based, there is associated bony reaction. I will discuss all of the features in my coming slides. So these are the features on the basis of which you decide that is it an extraaxial lesion or an intraaxial lesion, or it is a ventricular lesion or a cerebellar lesion. So there are different features on the basis of which you decide. So first of all, we will start with the fourth ventricular masses. I already discussed this medulloblastoma in my previous class, and it has got multiple varieties. We already discussed it is in an age group of almost 3 to 10 years. It has multiple subtypes, and one of the subtypes is lying in the fourth ventricle. And this subtype has a differential of ependymoma. So I will not again review the same findings which we already discussed in the previous class. We discussed that it is lying most of the time it is lying in the midline. It shows intense enhancement. At times it shows different restriction. It appears low on ADC mapping because it has dense cell packing. It has multiple drop metastasis. So we have to image the entire neuroaxis. This was another example which I already shared. And then we came to the differentials, and the differentials include atypical rhabdoid teratoid tumors, ependymoma, pilocytic astrocytoma, and choroid plexus papilloma. So few of these lesions are in the cerebellum, and we saw already in our slide that medulloblastoma can also have a cerebellar variety, and few of the lesions are in the line of fourth ventricle, and the medulloblastoma can also be in the fourth ventricle. So this is a typical, this is an atypical rhabdoid teratoid tumor, and these tumors, how we can differentiate them from ependymoma is that they are very heterogeneous. They have a cystic component, then they have a solid component, and then the cystic component shows peripheral enhancement, and then there is heterogeneous but intense enhancement of the solid component, and they are very huge, large. They also have multiple drop metastasis, so they are strong mimickers of medulloblastoma. And obviously, in the cases which are very overlapping in picture, histopathology is the gold standard. But on the basis of imaging, these cystic components are more typical of an ATRT. And then another strong mimicker is ependymoma, but we already discussed that ependymomas are WHO grade 2 tumors. They are not that aggressive. But the most differentiating features between a medullo and an ependymoma is that ependymoma is along the ependymal lining. So it will be seeping along the lateral and midline foramina. So you just have to focus on the midline foramen and the lateral foramen to decide that whether it is a medulloblastoma or an ependymoma. So it is a T2 intermediate signal intensity mass in the fourth ventricle. It has extensions through foramina of Bushra and Magendie into the CP angle cistern and the cervicomedullary junction respectively. Medulloblastoma and ependymomas are very two important differential considerations of each other in pediatric age groups in the lesions which are in the fourth ventricle. So this is another patient who had an ependymoma, and we can appreciate that this lesion is extending through the right foramen of Magendie. And so whenever you are trying to shortlist your differentials, and you are trying to differentiate between an ependymoma and a medulloblastoma, then you have to look at the signal intensity, the homogeneous characteristics of tumor. The origin is mostly from the floor of the fourth ventricle, although the patients who present to us, they have large masses, and we can't discriminate that whether the mass is arising from the floor or the roof, but still the typical presentation is from the floor, and it has extension into adjacent cisterns through the foramina. So these, just for the sake of comparison, I placed one image of an ependymoma on my left, and one is a medulloblastoma, and we can appreciate that this is a well-defined mass. It is very homogeneous, and it is going through the foramen of Bushra, whereas the medulloblastoma, it is not extending through the foramina, and there is this leptomeningeal metastasis and basal meningeal metastasis, and this metastasis is going in the spinal canal along the leptomeninges. So it has more drop metastasis, sugar coating kind of metastasis in cases of medulloblastoma. So these are the few discriminating features. Then if we come to the cerebellar hemisphere lesions, another very important lesion is the pilocytic astrocytoma, which is a large cystic mass in the cerebellar hemisphere, but it has an enhancing mural nodule, which is seen here on the sagittal post-contrast T1 weighted images. So this is a pilocytic astrocytoma in a pediatric. It is an important differential of a pediatric age group cerebellar hemisphere lesion. Then another important differential of an intense enhancing mass in the line of ependyma is the choroid plexus papilloma. With the choroid plexus papillomas, important features which you can see is that it is also a benign lesion. It is basically picked up due to overproduction of CSF. So it enhances homogeneously because choroid plexus is an intensely vascular structure, and the lesions of choroid plexus will also show intense homogeneous enhancement. And there can be signs of raised ICP in these patients as well, because these patients have excessive CSF production. If there is associated invasion, then you have to consider about choroid plexus carcinoma. So this is another important differential of posterior fossa lesions. They can be in the line of fourth ventricle. With this, we come on to the lesions in the brainstem. So the most important lesions are brainstem glioma, because we are basically focusing on the gliomas. But at this point, I would find this an opportunity to discuss different differentials in the line of pons specifically, because they are strong mimickers of gliomas, and they are mistreated in a lot of cases. So having a strong clinical history, detailed clinical history, and a high level of index of suspicion and familiarity with multiple MR sequences, you can narrow down the differentials of brainstem lesions. So they can be pediatric brainstem gliomas or adult brainstem gliomas. If you look at these images, then you can appreciate that there is, I've placed two sequences. This is a FLAIR and a T2 weighted sequence. We can see that the ventricle is hypointense on this sequence, and it is hyperintense on this. So we can't see gray white matter. So, but I know that this is a FLAIR sequence. For you to decide, you have to look at the gray white matter as well. So when you look at these images, you can appreciate that there is something in the pons which is causing its expansion. It is increasing the bulk of the pons, and it is returning heterogeneous signals on T2 and FLAIR images, and it is causing some mass effect and effacement of the fourth ventricle as well. But the most important and prominent feature is that it is increasing the bulk of the pons. And when you look at the plain and post-contrast T1, so you can again appreciate that there is something which is increasing the bulk of the pons, and it is causing some compression or effacement of the fourth ventricle, and then there is some heterogeneous kind of enhancement in this lesion. So this was basically a pontine glioma, and in this patient, spectroscopy was also advised. So for spectroscopy, we placed a voxel on the normal brain parenchyma, in which we could appreciate that there is normal NAA peak, whereas you all know that NAA is a normal metabolite which is found in the glial cells. And the choline and creatine, they have shorter peaks as compared to NAA. But in a voxel which is placed on the lesion, we can see that NAA has relatively reduced as compared to choline and creatine. And this Hunter's angle has reverted in direction. And then again, there is a lipid lactate doublet, which is depicting that there are some internal areas of necrosis, and we could appreciate these areas of necrosis on post-contrast images as well, that there is a non-enhancing center and there is peripheral enhancement. So this non-enhancing center is basically showing that there is some necrosis, because this center, which is hypo-intense on T1 and showing no enhancement, is minimally hyper-intense on T2 weighted images. So spectro at times is useful, but to the best of my experience, I've seen that spectro only adds or complements the baseline images. Still, we make our final opinion on the basis of baseline images. There are very rare situations in which spectroscopy will change your differential. So keeping in mind this lesion, I just wanted to share few close differentials of pontine lesions here, so that you are able to differentiate them. This is another patient who presented with a history of gastroenteritis, and there was some sodium correction in that patient. So here you can appreciate that on T2 weighted images, there is a peripherally preserved area of signal intensity, and then the central white matter traps, they are showing hyperintense signals on T2. There is no associated significant necrosis, and on FLAIR, these are also hyperintense, and although there is some increase in the bulk of pons, but the periphery of the pons is preserved, and this area is showing central diffuse restriction. So this was basically an active demyelination due to osmotic demyelination syndrome in a patient who presented with rapid sodium correction. So having the history of the patient is very important. As a radiologist, we try that we dig in the history from the patient, and we try to go through all the investigations, and if there is a pertinent clinical question, that becomes very helpful for us in narrowing down our differentials. This was another patient, and this patient also had some abnormal signals in the pons, but you can appreciate that there is a well demarked line which is dividing the pons into right and left halves, and the left hemi pons is having a geometric kind of distribution, and there is some hyper intense signals in this region. So this demarcation, geometric demarcation, goes in the favor of vascularity, that this side is divided by is supplied by left-sided pontine vessels. So this was basically a case of pontine infarct. So we confirmed that on the basis of diffusion-weighted images, but we know that osmotic demyelination also shows diffusion restriction, but there are diffuse signals in that. In cases of pontine infarcts, the signals are ipsilateral. They are divided by some geometric field which is dividing the vascular territories. So another companion case was, this was another case of osmotic demyelination syndrome in which there were central signals, and that was showing diffusion restriction. This was another case in which the patient was, I was discussing in my last meeting as well, that there was a case who was a doctor himself who was reported as a case of pontine mass, and he was advised radiotherapy as well in some hospital at Islamabad. And this patient, basically, when they focused on rest of the brain, we could appreciate a lot of ischemic changes, and the patient had a history of smoking for 20 years, and patient also had a cabbage surgery. So this was basically ischemic changes. And in these cases, when there are such perpendicular signals, you will also consider multiple sclerosis in such patients. But in this patient, we knew that there was no history of multiple sclerosis, but still when there are lesions at the septocallosal junction and they are perpendicular to the ventricles, you will consider multiple sclerosis as well. This is another companion case of pontine glioma, in which you can appreciate that there are diffuse there is diffuse signal change in the pons, and there is increase in the bulk of pons. And this is partially encasing, the bulk is so much increased that it is partially encasing the basilar artery as well. So this was another case of pontine glioma. This was another patient who presented to us with fever, and when we reviewed the images, we could see that there was T2 hyperintense area, and this area was showing peripheral enhancement, and there was a significant surrounding edema. And when we looked at the diffusion, unfortunately, I don't have the diffusion images, but this the center of this lesion was showing diffusion restriction. And the typical peripheral enhancement pattern, it was actually a pontine abscess, and patient had typical features of raised inflammatory markers and fever, and all the features which were going in favor of infective inflammatory process. So it was a pontine abscess, and in cases of abscesses, again, diffusion-weighted images, they help you a lot. But still, that we already discussed, that diffusion restriction can be there in cases of infarction, and it can be there in cases of acute demyelination. So then, keeping a history in mind and rest of the features on post, how does it appear on post-gadolinium images, how does it appear on plain T1-weighted images, what is the clinical presentation, where is the area of involvement, what is the distribution of the lesion, or what is it causing to the adjacent structure. So all these features, when you place all the pieces of jigsaw into their, you place all the pieces at the correct points, then you get the actual picture that what is going on inside the brain of the patient. So these are the different differentials of pontine lesions, which I already discussed. This is another slide in which there are multiple differentials of diffuse pontine hyperintensity. There can be toxic metabolic causes, there can be cerebellovascular causes, there can be infections, there can be gliomas. But again, you have to narrow down your differentials on the basis of multiple important features which I already discussed. Then there are pineal gland lesions which also appear in the line of tentorium. And to categorize these lesions, first of all, you should have a basic idea that what is the anatomical location of pineal gland. So basically, whenever you are looking at the sagittal images specifically, you have to look at the splenium of corpus callosum, the superior surface of cerebellar hemisphere, and the posterior surface of tectal plate. In between this region is the location of pineal gland. So whenever there is some vision line, here you have to consider a pineal tumor, and then you will narrow down your differentials on the basis of the age of the patient and different signal characteristics. So the pineal tumors can be pineocytoma or pineoblastoma, and then there can be germinoma. So we know that pineal lesions, they have normal physiological calcifications as well. If the lesion is engulfing this normal calcification within it, and the lesion goes outside the calcification, then this is a germinoma. But if it is bursting the calcification and taking it to the periphery, then this is a pineocytoma or a pineoblastoma. So this is a very important feature. You can either characterize it on the basis of CT scan, because CT is good for calcification. The other thing which can help you in looking at this calcification is the susceptibility weighted images. So the susceptibility weighted images, we discussed initially that they are important to pick up hemorrhage. There are three things which show which appear as area of signal dropout on susceptibility, and these are calcium, blood, and air. So if you look at a susceptibility weighted image and you try focusing on the paranasal sinuses, you will see that they are just appearing as black structures. So air appear as area of signal void on area of low signal intensity on susceptibility. Similarly, blood appear as area of dropout, and similarly calcification also appear as the area of dropout. So susceptibility can help you in characterizing the location of the calcification in cases of pineal lesions. So the difference between pineocytoma and pineoblastoma is that pineocytoma is a WHO grade 1 lesion, whereas pineoblastoma is a WHO grade 4 lesion. So it will be more heterogeneous, it will be more aggressive in feature, there will be multiple areas of internal necrosis, whereas pineocytoma will not be causing much mass effect on the surrounding structures. It is a relatively benign lesion. So with this, we move on to the cerebellopontine angle masses, and a very simple mnemonic for these is same. That is the schwannoma, aneurysm or ethmolysis, meningitis or METs, and epidermoid ependymoma and thoracensis papillomas. So the schwannomas, if we consider them, if we consider their frequency, then 8th nerve schwannomas are the most common, and after that, the 5th nerve schwannomas, they come into mind. So it is very important whenever you are looking at the schwannomas that you already had a very nice lecture by Dr. Fatma Mubarak on intracranial nerve imaging. So you know that there is a dedicated sequence, an additional sequence, which is a CIS sequence for imaging of intracranial nerves. So always when you have a patient with symptoms of trigeminal neuralgia or tinnitus or ringing in ears, and you have specific, you can make out that there is something going on with the intracranial nerves. Your clinical localization is being localized to intracranial nerves. Please do advise that the patient needs a CIS sequence, or do write the symptoms of the patient so that the technician knows that he has to perform some dedicated sequences for intracranial nerve. So apart from that, we perform a CIS sequence. Apart from the core sequences or baseline sequences, we perform a CIS sequence. CIS is also called BTFE. CIS is constructive interface in steady state, or balanced turbo fast echo sequence, BTFE. There are different vendor-based names. In different scanners, they are named differently. There are multiple tables available on Google, which have all the acronyms from different machines. They are going to give you the name. If it is called CIS in Siemens, then it is called BTFE in Philips, and they're all the acronyms, they are tabulated, available on Google. You can easily find them according to the scanner which is available at your center. So CIS is a very high resolution, heavy T2 weighted sequence. It's a 3D sequence, so very thin volume based images are taken, and you can appreciate very well the nerves on this. You can see, especially, for example, if you look at the image on my right, you can see that the 7th and 8th nerve, they are going towards from the cerebellopontine angle, they are going towards internal auditory canal. So there was, the patient had tinnitus. This was a case who presented to our hospital, but the patient did not have a CIS sequence. So we couldn't appreciate anything on the baseline sequences, but we ordered a CIS sequence, and we could find that there was a tiny schwannoma which was lying in the internal auditory canal, and it was not picked up from the rest of the sequences. But when we performed this high resolution to 3D sequence, which was heavy T2 weighted, and then we performed fat suppression along with that, we could appreciate this lesion very well. Similarly, this was a lesion in the line of 5th nerve, which was going towards the knuckles cave. So this was picked up very nicely on this sequence as well. So do advise this in your patients. So I will show you a few cases with these lesions so that you are able to appreciate them. Whenever you are looking at the base of skull and posterior fossa and you are appreciating that there is some extraaxial lesion which has a CSF cleft and it has a broad base, then you try to localize that. In the line of which nerve is this lesion lying? First of all, you have to make sure that this is in the line of nerve. For example, if you are looking at this lesion, this is an intensely enhancing homogeneous lesion in the right cerebellopontine angle. So I can easily call it a meningioma, but when I will look at the component which is going towards the internal auditory canal, and this component is also enhancing, which is going along the nerves. So this makes sure that this is not a meningioma, but it is going in the line of nerve. So this is this is a seventh or eighth nerve schwannoma. Eighth nerve is more common, so we call it, in our reports, vestibulocochlears are more common always. So similarly, if I look at this lesion, I can appreciate that this is going towards the Meckel's cave and it is in the line of fifth nerve. So this is a fifth nerve schwannoma. So just look at the epicenter and the course the lesion is following, and that is very important. There are multiple non-vestibular schwannomas as well, which can be trigeminal. They can be in the line of jugular foramen. They can be in the hypoglossal facial. I haven't, included all those images because they are very rare. They comprise hardly 1 to 5% of the schwannomas. So, but to categorize them, you just have to follow different foramina, and you just have to follow the line of growth of tumor. And similarly, for example, if you are looking at a schwannoma which is of the glossopharyngeal nerve or hypoglossal nerve, so just look at the muscle supply, look at tongue muscles, look at the trapezius if you're looking for accessory nerve involvement. So there are multiple indirect indicators as well which show you that the lesion is involving which of the nerves. So this was another patient. Always remember that whenever you are looking at multiple schwannomas, especially in a younger age group, so there are multiple syndromes which should come to your mind when you are looking at the posterior fossa. The posterior fossa is notorious for a number of syndromes. Even if there is infarction, there are multiple syndromes. There is a lateral medullary syndrome or a medial medullary syndrome. Similarly, if you are looking at multiple schwannomas, just think about neurofibromatosis too, because this was a patient who presented for cyberknife to our hospital, and this patient had bilateral eighth nerve schwannomas which were extending in the internal auditory canal, and then there was another schwannoma which was going in the line of fifth nerve. If you look at this image, you can appreciate that there is something in the base of skull. You can see that there is difference in the symmetry of this pterygoid plates and pterygoid muscles on right and left. And here you can appreciate that there is foramen ovale and foramen spinosum, but you can see that there is some growth which is expanding this foramen. So this is basically the V3 division schwannoma. So this was a large fifth nerve schwannoma which was extending along the V1 division. We can appreciate that this is reaching the orbital apex, and then this was expanding the V3 because we can see that the normal foramen ovale is seen on the right side but not seen on the left side. And then there were associated broad-based lesions which were meningiomas, and these had enhancing dural tails as well. You can see that the dura is enhancing here, but it is not enhancing on the contralateral side. It is very interesting in brain that you have two sides, and it is so easy to compare right and left. At times you are confused that this is something artifactual or something I'm overcalling. So you can always compare the right and the left, and it becomes very easy to further categorize your lesions. And there was a parafalcine meningioma, and then there was a meningioma posteriorly in the line of superior sagittal sinus along its posterior aspect. So this was a case of neurofibromatosis 2. So in neurofibromatosis 2, always remember this little mnemonic miss me. There are multiple inherited schwannomas, meningiomas, and ependymomas. So if you are finding multiple meningiomas, try to look for schwannomas and ependymomas. Similarly, if you find multiple schwannomas, try to look for the other two. And believe me, you find them. If you start focusing, very scrutinizing the images in depth, you start finding multiple things. Because if you have it in your mind, because eyes can't see what the mind doesn't know, if you have it in your mind that there can be some syndrome in this patient, I should try to look for that. You will find things of it. This is another patient who has a CT angle meningioma, and as I was telling you, we just focus on the intracanalicular component of eighth nerve. So on post-gadolinium images, you can see that the intracanalicular component is not enhancing. And then there is an enhancing dural tail. Although on plain images it appears that it is in the line of the 7th and 8th nerve, and it is vestibular cochlear schwannoma, possibly, but when you look at the post-gadolinium images, there is no enhancement. And then there is a dural tail, so this was a meningioma. In meningioma, you have to look at common radiological features. You have to look at the CSF cleft, as these are extraaxial lesions. You have to look at this buckling of gray-white matter. You can see that this gray matter is displaced anteriorly. You have to look at the dural tail. Then you have to look at this sunburst kind of appearance. There is associated bony hyperostosis. The bone is different from on the right as compared to the left. We can see that there is some irregularity and hyperostosis of bone. Then there can be pneumosinus. There can be bone invasion by meningioma. There can be skull-based meningiomas which can invade, rest of the structures at the skull base. Then the meningiomas, they can cause narrowing of the carotid. If you focus on in the region of cavernous sinuses, this is right ICA. This is left ICA. This is encased by this meningioma, and there is significant narrowing. Then there is invasion of the cortical veins or superficial cortical sinuses. So these are all common radiological features of meningioma. Then there are multiple other simple benign things, which are cystic lesions, which can be in the CT angle. And these can be arachnoid cysts, and these can be epidermoid cysts. So how you differentiate that? Is it an epidermoid cyst or an arachnoid cyst? Is because both of these are cystic lesions, and most of the times they are following the same signals on T1 and T2, just like CSF, hypointense on T1, hyperintense on T2. So which sequence plays the most important role in differentiating is the diffuse weighted images. At times, there are dirty CSF signals on flare in the epidermoid cyst, but the most important sequence is the diffuse weighted images. On DWI, this is following CSF signals. Like fourth ventricle is hypointense on DWI. Similarly, this area in the right CP angle is also hypointense on DWI. So this is an arachnoid cyst. The arachnoid cyst is a CSF containing structure. So keep it in your mind that it will follow all the CSF signals on all of the pulse sequences, on T1, on T2, on flare, on diffusion, on ADC. So every sequence is going to return the same CSF signals in cases of arachnoid cyst. But in epidermoid, this is an epidermoid cyst. It is hypointense on T1. So here comes the role of DWI, and on DWI, it is going to show you diffusion restriction. So the important lesions which lie in the CP angle, I've discussed all of them one by one. There can be few other lesions, like for example, this patient had metastasis. We knew the history. That patient was a known case of CA breast. This was a case of secondary CNS lymphoma. Basically, the patient had widespread lymphoma in the body, and then developed another deposit. So lymphomas on ADC, they give a low ADC. They appear low on ADC map because there is dense cell packing in lymphomas, lymphomatous deposits. So they will be low on ADC. So this helps you. First of all, the history helps you. You know the history that the patient already has a primary lesion, and then you are in the light of that history, or reporting your scan. So the things become quite clear having the history. Similarly, this was another case, and there was a lesion in the left CP angle, but this was hyperintense on plain T1 weighted images. So how do you know that these are plain pre-contrast T1 weighted images? Is I told you in my last lecture that you have to look at the nasal mucosa. There is no enhancement in the nasal mucosa. So it is already bright on the T1 weighted images. And if you look at the scalp fat, this is also bright. So in this case, we performed fat suppression images. Thus, fat scalp also suppressed, and this lesion also suppressed. So this was basically a lipoma in the left CP angle. So never, see your T1 weighted images in T1 post-contrast images in isolation. Always compare plain T1 and post-contrast side by side, because you can, if you would have looked at post-contrast T1 weighted images, you would have considered that there is some intense enhancing lesion in the CP angle. But if you look at the T1 plane and post-contrast side by side, then you know that these are lipomas, because they are already bright in on plain T1 weighted images. And then in that case, either CT or fat suppression images help you. This was another interesting young patient. He presented to our neurology clinic, and the neurologist sent me the scans, and the patient had significant tinnitus and ringing sound in the right ear, and he was, an office worker. and he had a lot of work using headphones and things. And whenever he used to place headphones, he used to feel more ringing pain. So when we imaged the patient, we could see that there was a bubbly kind of lesion in the right CP angle, which has a T2 hypointense rim and multiple bubbly cystic areas inside the lesion. So we looked at the susceptibility weighted images, and there was complete dropout on this. So basically, this was a cavernoma. So there can be vascular lesions in the CP angle as well. So this was a right cavernous, right CP angle cavernoma. So in cavernomas, there will be a complete hemosiderin rim, which will be completely hypointense on black or black on T2 weighted images. So, if you have a good knowledge of your baseline sequences, you can appreciate your lesions very well. This was another patient who had a posterior fourth ventricular lesion, which was hyperintense on T2, hypointense on T1. So on T1 and T2, we could see that it is returning CSF-like signals. But when we performed the DWI, we could see that there was different restrictions. So this was an epidermoid in the fourth ventricle, and this was not showing any significant enhancement. So this was another patient who had a large, glomus tumor, and this was infiltrating the base of skull, and it was reaching up to the CP. It was reaching up to the pons, and this was, the clivus is seen clearly separately, and it is an intensely enhancing lesion. These are the CT images, and this was a case of glomus tumor. This was another patient of CA breast, and we could see that there were multiple ring enhancing lesions, supra and infratentorial. So in cases of ring enhancing lesions, we consider tuberculosis as well, but this was a patient who had a history of CA breast. And if you appreciate, you can see that almost all of the lesions are lying at the gray white matter junction. So that is again, a very important feature, that if there are multiple lesions which are at the gray white matter junction and they have disproportionate edema, then you have to consider metastasis in an elderly age group specifically. So we will just quickly go through these images, and you can write in the chat box. I will just quickly go through these images. There were bilateral masses in the CP angles, and there was some enhancement in the left CP angle mass, some subtle enhancement in the right CP angle mass. So this was basically a case of neurofibromatosis too. I can't hear you, Fatma. I think you're not unmuted. Yes, somebody said that this is NF2. Correct, absolutely correct, because when we look at rest of the images, we can see that there are multiple peripheral broad-based lesions which are neurofibroma. So it was a case of neurofibromatosis too, and it had, as we discussed, the mnemonic myasthenia, there were multiple inherited schwannomas, and then there were meningiomas. So this was another patient. It was a case of von Hippel-Lindau disease. This was actually a pregnant patient who presented to us with gait imbalance, and patient was in her third trimester, and we advised MR. She was advised MR by the neurophysician, and when we performed this, we found that there was an intensely enhancing lesion in the left cerebellar hemisphere, and we could appreciate the vessels entering the lesion. So we performed ultrasound abdomen as well, and there were pancreatic cysts, and this was a case of hemangioblastoma, and the patient had all the spectrum of VHL. So after her delivery, her surgery was performed, and she's doing very well. She comes for regular follow-up scans. What is this tumor? So there is a left CP angle mass, and it is extending in the internal aortic canal. Yes, this is a schwannoma, vestibulocochlear schwannoma. So these are unilateral in 90% of the cases. If they are bilateral, you have to consider NF2. Yeah, if already discussed the answer, it's a vestibular schwannoma. This is another lesion. It is the second most common tumor in children, posterior fossa lesion. Already discussed in our previous slides. So this is a medulloblastoma. This is another lesion, cystic lesion with peripheral enhancing nodule in the right cerebellar hemisphere, causing some effacement of fourth ventricle in a pediatric age group. Yes, this is a pilocytic astrocytoma, good. These are usually benign. They're most common in children. They are low-grade lesions. So this is an interesting case. This is a scan to test whatever you have learned. So there are multiple lesions in the posterior fossa. I'm giving the description and I'm looking at the chat box, what is coming in the answer. There are multiple ring enhancing lesions. There is a larger lesion. These are DWI images. This lesion is showing diffusion restriction. This is a young patient, 18 years old. So yes, these are multiple tuberculomas, and this is a tuberculous abscess, right? So we can see that there are multiple, areas of T2 hyperintensity. So when we gave contrast, all of them blew up. So this was basically tuberculosis, and we can see that one of the lesions is showing central diffusion restriction, and that was a tuberculous abscesses. And apart from that, there were multiple tuberculomas. Few of these tuberculomas, they are showing T2 hypointensity. So the caseation necrosis of TB is hypointense on T2 weighted images because of certain metabolites and certain internal contents. So it is, if you look at this lesion, this smaller lesion, it is hypointense on T2. It is showing peripheral restriction, and it is showing peripheral enhancement and peripheral restriction. So this is basically a tuberculoma, but this one which is showing central restriction, and this is a tuberculous abscess. So this is how you differentiate between an abscess or otherwise enhancing lesion. So this was a young female. This is another patient in which there was a lesion. G.
Can you go back to the previous one? I just thought maybe we can have some discussion also on that one.
Yes,
so
sure.
I saw a lot of answers coming as Mets, and that was good thinking, because the multiple lesions posterior fossa में हर जगह पर है, तो Mets definitely सोचना है आपने, लेकिन फिर आपने age बताई तो फिर I think everybody started to figure out कि yes इतने age में नहीं होगा. मैं एक चीज खाली पॉइंट करना चाह रहा था, अगर लोअर राइट लोअर इमेज देखें हम, ये वाला लोअर इमेज में जो है ना, this is very typical of tuberculoma, like ऐसे clusters 2-3 बने हुए ना, one can still, you can still get a metastasis like this. I've never seen a metastasis like 3 clusters ऐसे बने हुए. So
like it's a bunch of wave kind of a lesion.
जी हाँ. तो जो posterior fossa में है, those lesions, you can say हाँ maybe, क्योंकि आपको जो है उसमें भी metastasis में भी कई दफा आपको मिल जाता है diffusion restriction वाला, right? तो
जो मेरी अंडरस्टैंडिंग है और जो मेरी जितनी रीडिंग है और ऑब्जर्वेशन है, you don't find a central diffusion restricted area in metastasis. आपको peripheral restriction जरूर मिलती है metastasis में. You can confuse this lesion as a metastasis because there is peripheral restriction. So enhancing part है metastasis में वो restriction show करेगा. But when there is central diffusion restriction ना, you will not consider until and unless otherwise it had been a solid enhancing lesion. तो मैं जरूर सोचती कि ये Mets हैं और restriction show कर रहे हैं because of then cell stacking. But when there is a central necrotic component, it is a large lesion, T2 hyperintense center, T1 hypointense center, and peripheral enhancement, and then you are getting different restrictions. So you should never, the main purpose of showing this case was, if it had been only this area, then you can consider this as metastasis because there is peripheral restriction. So ये discriminating छोटे features हैं जिससे we can, we can reach a, even if you don't have the age.
एक चीज मैं ये भी सोचता हूँ कि lot of people don't have access to high quality MRI in Pakistan. In a 0.3 Tesla पे एक contrast enhancing दो plate बन जाती है, T1 T2 और T1 with contrast. तो it's just that कि जो आपने दिखाया ना right lower में, that was so typical of TB. So I just want to point.
Also, Dr. Shumaila, I want to ask one question. How important is ADC imaging when we see at DWI? How important that we should have and we should look for ADC as well, because the hyperintensity on DWI can also be a T2 shine through, right?
Yes, exactly. You have to look at the ADC image in any case, because they complement each other. You can't read one image without the other. You need both of them. I did not place because, I have limited space on my slides. But whenever you are looking at a DWI, you can't comment on a DWI in isolation. You need an ADC map side by side in any case. For example, you are looking at an infarction and you have to, age that infarct. You need DWI and ADC side by side to decide that it is an acute infarction or subacute, or it is a chronic established infarction. Similarly, in cases of abscess, in cases of lymphoma, every time whenever you're looking at a DWI, you can't look at it in isolation. The way I told you that you can't look at a post contrast T1 in isolation without looking at a plain T1. Same goes the case with DWI. The DWI and ADC, they complement each other, and looking at one and commenting is absolutely incorrect. You need both of them to complement each other to give the correct, answer.
Good, great answer, and great question, great answer.